and I'll be the moderator for today's event. I'm a multiracial woman with tan skin, curly dark short hair, and I'm wearing a black shirt and some green leaf earrings, sitting in my home office with a window, some plants, and wall art behind me. Before we get started, I'd like to mention a few housekeeping items. First, transcripts are available for this webinar. Please note that this webinar is being recorded and will be sent to participants, as well as made available on our website. Throughout the presentation, please feel free to submit any questions you have through the Q&A button located at the bottom of your Zoom screen. We'll answer any of your questions at the end of the discussion. This 90-minute webinar will begin with AHI and speaker introductions, followed by a storytelling youth video. Clinicians will guide participants in doing a values clarification exercise, share best practices for providing adolescent-centered care, for example, specific language and phrases to use, resources including new educational material by Power to Decide and the American Academy of Pediatrics to share with adolescents on pregnancy options, and go through an interactive set of cases to practice adolescent-centered pregnancy options counseling. Then a legal expert from If, When, How will review the legal landscape shaping the provision of comprehensive pregnancy options counseling and resources for ongoing support. We will conclude with a Q&A period where clinicians, legal experts, and youth will be available to answer audience questions about the provision of adolescent-centered pregnancy options counseling. The Adolescent Health Initiative is based out of the University of Michigan, but we provide training, technical assistance, consulting, and resource development to healthcare providers, health systems, and youth-serving organizations across the country. Our vision is to transform the healthcare landscape to optimize adolescent and young adult health and well-being. Laura Kirkpatrick uses the pronouns she, her, and is an assistant professor of pediatrics at UPMC Children's Hospital of Pittsburgh. She developed a curriculum on pregnancy options counseling with adolescents for pediatric residents that has been implemented at multiple residency programs in the United States. Her research interests are in best practices for pregnancy options counseling with adolescents, as well as reproductive health care for adolescents and young adults with neurologic conditions. Robin Watkins uses the pronoun she, her, and is a white cisgender female with long light brown hair and blue eyes. She is the Senior Director of Healthcare at Power to Decide. She is also a certified nurse midwife and women's health nurse practitioner whose work at Power to Decide is focused on leveraging human-centered design principles to create and enhance patient and provider resources, deliver trainings driven by equity and informed by the best available medical evidence and clinical guidelines, and expanding the reach of Power to Decide resources such as Bedsider and Abortion Finder. Dr. Melissa Kotke uses the pronouns she, her, and is a professor in the Department of Gynecology and Obstetrics at Emory University in Atlanta, Georgia. She completed a fellowship in complex family planning and is the medical director of the Teen Services and Family Planning Clinic at Grady Memorial Hospital. She's the director of the Jane Fonda Center at Emory, which is involved in research and program development focused on adolescent sexual and reproductive health. She also serves as the medical consultant for the state of Georgia's family planning program and the maternal co-chair for the Georgia Perinatal Quality Collaborative. Current areas of research include dual protection, over-the-counter contraception, and ways to improve sexual health for teens. Hannah Hu uses the pronouns she, her, and is an Asian teenager with medium-length straight, black hair, and brown eyes. She is currently a rising junior in Michigan and hopes that by participating in this webinar, she can not only learn more about herself, but also help raise awareness to other people. In her free time, Hannah enjoys hanging out with her friends, practicing piano, and binge watching her favorite TV shows. Elizabeth Ling uses the pronouns she, her, and is an Asian cisgender female with black hair and is wearing black framed glasses. She is the senior helpline counsel at If, When, How, where she manages the Repro Legal Helpline, which answers legal questions around a variety of reproductive experiences, including self-managed abortion, youth access to abortion, and birth justice. Elizabeth began her career as a family defense attorney with Brooklyn Defender Services, representing parents facing allegations of abuse or neglect and helping them to reunite or keep their families together. Before we continue any further, let's review today's objectives. During today's webinar, we will learn about tangible strategies and resources to support decision-making autonomy for adolescents who have a positive pregnancy test, learn best practices for providing adolescent-centered care, for example, specific language and phrases to use, practice adolescent-centered pregnancy options counseling, and lastly, learn about the legal landscape and available resources to you. Now I'd like to share with you a short video that describes a firsthand account of an adolescent's first experience after they found out they were pregnant.
When I first learned I was pregnant, I had no idea what I wanted to do. I was the only person that could make the decision of whether or not I wanted to keep the pregnancy, but I felt like the least capable person to decide anything. I had a lot of loose puzzle pieces and no guide on how to put them together. The more I tried to piece everything together, the more I realized that there were questions my partner and I could simply not answer. As an international college student, my first access point to healthcare is through my on-campus primary care services. So I scheduled an OBGYN appointment, hoping that it would answer some of the questions we had. Instead, I received a small lecture on birth control. The provider sent me home with a couple of informational booklets and a referral for an abortion provider, as in their words, that is what college students do. The questions I had before remained. So I used this referral to schedule an appointment at an OBGYN specialized clinic. This time, I received a lot of information about what the next stages of my pregnancy would look like. I had an in-clinic ultrasound and I got to hear the fetal heartbeat, regardless of whether I actually wanted to. No one ever asked me what I wanted to do, but they just assumed that I was keeping the pregnancy. Every single staff member in the clinic that day said congratulations. And for a brief moment, it felt like my birthday. However, I did not even feel comfortable bringing up abortion during that appointment. It took 2 more months until I was ready to make a decision about my pregnancy. I had spent countless hours doing research to answer the questions that had been clouding my mind since I first learned about my pregnancy. I still don't know what a pregnancy would have fully looked like for a 22-year-old international student with an autoimmune disease. But I am sure that having an abortion at 21 and a half weeks was the right decision for me.
And now we have Dr. Laura Kirkpatrick.
Hi, I'm just trying to figure out how to take control of the slides. I'm sorry.
No worries. I think you can just use the arrows.
I don't see arrows.
On your keyboard?
Oh, like, okay, now I understand. Sorry about that. I'm technologically not the most sophisticated person. So hi, everybody. I'm Laura Kirkpatrick. I'm at the University of Pittsburgh and UPMC Children's Hospital of Pittsburgh, and I'll be talking about values clarification and best practices for adolescent-centered pregnancy options counseling. I'm trying to use the arrows and they are not advancing the slides. Oh, now they worked. Okay. Sorry. So first, I'd like to share some context about the Dobbs decision. You'll be hearing about this in much more detail later in this presentation from Elizabeth Ling from If, When, How. But just to kind of set the stage, I just wanted to mention that in the aftermath of the Dobbs decision, 14 states have banned abortion, 8 states have bans under litigation, and there were over 30,000 fewer abortions in the 6 months following Dobbs than would have been expected based on data on prior abortion rates before Dobbs. And as most of us all know here, abortion restrictions may disproportionately impact young people, both because there are restrictions that specifically target young people, and because restrictions that apply to everyone might be even harder for young people to meet if they have, for example, more limited resources. So this is the climate in which we're thinking about providing adolescent-centered pregnancy options counseling. And obviously we want to empower young people to feel like they can make choices that are right for them, while also being honest about the environment that we're working in currently. My slides are still not advancing. Maybe you guys should just take over the slides and I can say next slide. I'm sorry about this. So pregnancy options counseling is the comprehensive discussion of possible pregnancy outcomes with a pregnant person, including parenting, adoption, and abortion. And ideally, it should be free from judgment or bias. Next slide. It is the ethical standard of care for pregnant people of all ages, including adolescents, and it's endorsed by the American Academy of Pediatrics, the American Academy of Family Physicians, the American College of Nurse Midwives, and the American College of Obstetricians and Gynecologists. Next slide. In terms of my own connection to adolescent-centered pregnancy options counseling, I led a study in which myself and my team conducted qualitative interviews with 50 US individuals who reported a pregnancy before the age of 20 years old regarding their experiences and preferences for pregnancy options counseling during adolescence. And in this study, we aim for thematic saturation for subgroups who experience parenting, adoption, and abortion during adolescence. The results of this study were recently published in Journal of Adolescent Health. We also have a paper that's specific to adoption in Journal of Pediatric and Adolescent Gynecology, and a couple of other things under review or in progress. Next slide. I used the findings from the study to develop a curriculum on adolescent-centered pregnancy options counseling for pediatric residents. And in developing this curriculum, I collaborated with 17 key stakeholders, including 5 people who experienced adolescent pregnancy and 12 community and healthcare professionals, to ensure that the curriculum was optimally patient-centered and also responsive to the needs and ideas of people serving this population. The curriculum is structured as a values clarification exercise, a brief didactic, and then opportunities for participating residents to role play pregnancy options counseling with a standardized actor portraying a pregnant adolescent. And so far, it's been implemented at 3 pediatric residency programs. If you would be interested in having such a training at your site, whether or not it's a residency program or not, please don't hesitate to reach out. Next slide. So let's engage in the values clarification at this time. This exercise is for you to have a chance to think introspectively about your thoughts and feelings toward pregnancy during adolescence. And the reason for this is, as I mentioned previously, options counseling ideally should be devoid of judgment or bias, but as human beings, we've all had sets of experiences, we have our own beliefs and challenges that we carry with us. And the best thing we can do is to become self-aware of what biases we might hold so that we can mitigate their impact on counseling and be able to give young people the kind of judgment-free zone that they deserve. So we're going to read through some cases, and as we do so, please reflect on what thoughts or feelings come up for you, and how do our personal values impact our ability to perform unbiased options counseling. Next slide. So the first case that I'd like for us to reflect on is that of Destiny, who is a 17-year-old Asian American young woman who is currently parenting her 14-month-old son, Charles. She lives with her grandmother, who is highly involved in caring for Charles while she attends high school. Destiny is pregnant now and intends to parent her second child. However, her grandmother is upset with Destiny because her grandmother feels personally overextended and does not think their income can support another child. Next slide. I'd also like for us to think about the case of Olivia, who is a 14-year-old white young woman who became pregnant by her 14-year-old boyfriend. She thinks she is too young to become a parent and would like to focus on school for the next several years. Her parents are politically conservative Christians who believe abortion is murder. Although Olivia herself is not sure what she thinks about abortion, she decides to pursue adoption because she thinks her parents will be happiest with this decision. Next slide. And finally, I'd like for us to take a moment to reflect on the case of Sam, who is a 16-year-old African-American non-binary person who is now 18 weeks pregnant. They first took a pregnancy test, which was positive at 6 weeks of pregnancy, but we're hoping the result was a mistake. And despite noticing changes in their body, held out this hope until recently when they decided to take another test. They would like to pursue having an abortion and do not want their parents to find out that they were ever pregnant. Next slide. So please inwardly reflect on these questions, thinking of the scenarios on the previous slides. How do you navigate internal conflicts when interacting with patients? And what strategies can we use to practice emotional intelligence in our patient encounters? So taking a moment to reflect on this ideally can help us, figure out how to identify and also mitigate and work with, the biases and attitudes that we all carry with ourselves. Next slide. So now that we've reflected on our personal values and how they might impact our counseling, let's talk about best practices for pregnancy options counseling with adolescents. Next slide. So I'm going to be sharing some quotations from the study that I mentioned. They will be in blue boxes, and all the names are pseudonyms. So first of all, this might sound really straightforward, but it's important to inform patients privately if a pregnancy test will be ordered. And I wanted to share the experience of Maria, who was in an emergency department and who was brought back for an ultrasound without having been informed that she was undergoing a pregnancy test or that it was positive. As she said, at least just get an initial sit down before I even walk into the ultrasound room. Next slide. In terms of setting the stage to talk about the pregnancy test, please do so in a confidential manner. Our young people really value clear confidentiality parameters. So please ask others in the room to step out, and it can be helpful to suggest where to go. For instance, if a waiting room is available, and it can be helpful to use normalizing language. For instance, in our facility, we have a policy that we speak to all youth privately. As Destiny said in our study about, having facility staff talk to her in front of her parents, they started asking me questions about my sexual experiences and things like that. And it was just really awkward because I'm like, can you guys do this alone? At this point, I was just like, you guys already made me uncomfortable. And so I was upset and irritated. Everything they were asking me, I kind of just brushed it off and didn't really care to answer anything else. Or Faye described the experience of having pregnancy test results disclosed in front of her boyfriend. I was like, I should be getting told this like alone. is how I felt about it, just so I can have a minute to process it before I decide like what I want to do. Because I think my initial reaction was like, oh, he doesn't want a baby. I really don't want one. But I was really thinking about how he felt about it. Next slide. When setting the stage, it can be helpful to sit down if it's feasible to do so in the room, because this can create a more comfortable communication environment. And it's a good idea to gently remind the young person that a pregnancy test was ordered and ask if it would be okay to discuss the results now. As Elise said in our study, I would want them not to just barge in and say, I have your results and tell me. How she, referring to her doctor, came in was nice and said, I have your results. Are you ready to hear them? And then I said, yes. Next slide. The language we suggest using for disclosing a positive pregnancy test is your pregnancy test is positive, which means that you are pregnant. Directly saying you are pregnant is important because just saying that a test is positive can be confusing and unclear. And it's really important to maintain neutrality and not assume what someone's reaction is going to be. So please don't say anything like congratulations or I'm sorry. Next slide. As you're delivering this news, it's important to allow silence and time to process the news if that's needed. You can check in with an open-ended question like, how are you feeling? And again, avoid making any assumptions about the young person's intentions, emotions, or experiences. Annalise said something in our study that really illustrates the power of the open-ended question. She said she was the first person who was like, are you okay? Like, how are you doing with all of this? And then I felt comfortable disclosing that it had been non-consensual. Next slide. In creating a judgment-free zone with compassionate communication, there's several existing communication models that can be helpful to remember. One is the nurse model for discussing emotions, and that includes naming, understanding, respecting, supporting, and exploring. There's also the ORS model of communication, which entails open-ended questions, affirmations, reflective listening, and summary reflections. The importance of compassion is illustrated by Shelby, who says, one thing, when you see the doctor talking to you in a respectful manner, it makes you have a little hope in the situation. Alternatively, Alex shared a negative experience. It felt like there was that judgment that I had talked about of you're in this situation and you shouldn't be. And so to kind of fix it, you should choose adoption. It just didn't feel supportive. It felt more judgy and invalidating to what I needed at that point. Next slide. You can check in with the young person about their kind of thoughts, feelings, and intentions. You can ask something like, have you thought about what might be right for you? Or have you thought about what you might do in this situation? Next slide. And when you're having this conversation, you want to be comprehensive. You want to at least touch upon parenting, adoption, and abortion, all of these. And you want to use very clear, very plain language, or as Marcy said, communicate with people in language they can understand that is not euphemistic. Around parenting, we recommend just saying parenting or become a parent, but avoiding language like keep the baby, have the baby, or become a mother. Around adoption, you can say adoption or make a plan for an adoption, but avoid give the baby away for adoption. And around abortion, it's good to be clear and at least initiate the conversation with the word abortion. However, if the patient seems more comfortable with a euphemism like termination or end the pregnancy, it's okay to reflect their language for their comfort after you've used the word abortion at least once for clarity. But obviously, we don't recommend echoing language that's very value-laden, like murdering or killing. Next slide. When discussing the options, it's important not to neglect or belabor any particular option, but stay neutral and supportive of all possibilities. In healthcare, sometimes we're most comfortable in the factual domain, but it's a good idea not to information dump or lecture, particularly if the patient is feeling overwhelmed, and you can follow their lead and ask something like, would you like to talk more now about any of these options? And Nevaeh and Danita from our study illustrate a couple of ways of talking about the options. As Nevaeh said, hey, if you think you can parent, you can. If you want to have an adoption, this is how it'll work. There's a lot of great programs. If you want to have an abortion, this is how it would work. And Danita said, you should operate very neutral and kind of just very middle of the road and very moderate in your decision and not show your feeling one way or the other. Like I look at it like be like Switzerland. Next slide. Many adolescents will know immediately what they want to do, and many may have already known about their pregnancy before coming to a healthcare facility and may already have a decision in mind. However, ambivalence and uncertainty are very common, and we should be prepared to address these circumstances. Next slide. It's important to provide reassurance to a young person who's ambivalent that they don't have to make a decision right now, and they have time to reflect and make a decision that's right for them. However, this kind of reassurance needs to be counterbalanced about clarity, about encouraging a timely decision, whether that's initiating prenatal care or planning for an abortion. Adolescents have been shown to present at later gestations for both prenatal care and abortion care for many reasons. And so it's especially important to be clear about timeliness. Next slide. And that discussion of timeliness can include honest information about the accessibility and gestational limits for abortion in your area or the closest areas where abortion is accessible. And if a young person is thinking about abortion, it's okay to at least provide a little information that while abortion is very safe, it may increase in complexity, cost, and time required for the procedure, depending on the patient's gestational age. Next slide. It's also important to note that in doing options counseling, you don't need to be an expert on all the options, but ideally you should know at least a little bit about each possibility and where to refer young people for reliable information. It's also a good idea to provide resources that young people can review later on, both in terms of information and referrals for next steps in care. Next slide. It's important to validate and support all pregnancy decisions. As Elena said, she didn't really give me many resources or talk to me much about keeping my daughter. She just talked a lot about adoption and abortion and stuff. And so I don't know, I felt kind of weird saying that I wanted to keep her. So I don't know, I kind of stopped listening. Next slide. In terms of discussing continuing pregnancy, it's a really good idea to know about options for prenatal care in your area, as well as governmental and charitable assistance for pregnant people in your area, but really try to know those referrals, in particular because of the phenomenon of crisis pregnancy centers that purport to help pregnant people, but are really just exist to dissuade people from abortion. And there are, of course, legitimate sources of assistance that might be faith-based or have kind of ideological leanings. And I think it's good to be transparent with patients about that so they can make a decision regarding where they're comfortable seeking help. For people discussing continuing pregnancy, it's also important to have some short talking points around prenatal vitamins, review of medications, tobacco, drugs, alcohol, STI screening, and the importance of timely prenatal care. Next slide. It's important to validate and support young people who are deciding to parent, which can indeed be a positive experience for some young people. And it's good to know what supports or resources might be available in your community for new parents, particularly adolescents. As Bobby said, adolescents who choose parenting desire the tools and the knowledge and hopefully the resources to get support from somewhere else or to get out of a bad situation or to help themselves. Natalie points out that those resources are often not available. There aren't resources available that can immediately take you from living paycheck to paycheck to, okay, now I have this scholarship to get me into a certification or something to help me get that next level up to take care of my child and to take care of myself and not have to worry about if I'm going to have a roof over their heads or food on the table. I think it's more of a deep issue than it is of just what information or how a healthcare provider could help in that situation. So this kind of points out that kind of in the bigger picture, I think as a society, we also need to do more to help and support people who are parenting. Next slide. It's important to validate and support a young person's decision to plan for adoption. Again, have some knowledge of local and national referrals and, try to understand those referrals. Not all agencies are pro-choice, although some are, and many are faith-based. And I would be upfront about that. It's good to know a little bit about open versus closed adoptions. Closed adoptions being kind of the model we think of in the past of there not being any contact between the birth parent and the adoptive family and the child. Whereas in open adoptions, there might be a continuum of some degree of contact and the young person might have some choice or control in deciding how much openness they want, as well as the family they'd like to place the child with. However, openness is not legally enforceable and is not co-parenting. So sometimes there might be some disappointment about the outcome of that. Adoption is a legally binding agreement, generally officialized no earlier than 48 hours after the birth of the child, and it isn't foster care or child welfare. Next slide. In terms of abortion, please also validate and support a young person's decision for abortion. Keep a good list of referrals to providers or sources of information. In my area, I discourage people from Googling for abortion providers, again, because of crisis pregnancy centers. So I just try to provide the referrals for providers that are legitimate in my area. It's important to know the laws in your area, including the legal availability of abortion and gestation limits. And then as we're talking about young people, it's really important to know about parental consent and notification laws, as well as the option for judicial bypass. And if there's any resources in your area that assist people with obtaining judicial bypass. And then you also want to know what resources are available for financial or practical support assistance in your area and nationally. Next slide. In states where abortion is available, know your local providers, including gestation limits for medication and surgical abortion. If you're in an area like I am, where a lot of people are now coming in from out of state or out of the area, volume might be up. It might have affected wait times, in which case it's really good to know how long it might take to get an appointment. In more restricted areas, it's good to know about the closest out of state or out of area options, or at least where to find high quality information, such as abortionfinder.org. It's also good to know about options nationally for later abortion care, where to find information. Next slide. In addition to discussing options, it's a good idea to get a sense of the young person's safety at home and in their relationships, particularly since pregnancy can be a time of heightened risk for violence. And it's good to have referrals locally and nationally that you can give to people or involve social work if available in your practice. And these referrals can be given to everyone, taking a universal education approach. And you can use language like, if you or someone has this concern, this information can be really helpful. Next slide. Similarly, I recommend providing universal education around crisis resources for mental health emergencies. And some suggested language is, for some people, but not everyone, becoming pregnant can be a major life change, and life changes can be stressful. For that reason, we give everyone we see who is pregnant this card in case they or someone they know experience a crisis or emergency related to their mental health. Next slide. It is also important to find out if there's anyone in their life that they would like to inform about the pregnancy. You can help with brainstorming a safe adult that they can talk to, and you can even offer to help support in making a disclosure of the pregnancy to that person. Often it might be the person who accompanied them to their appointment, but that's not always the case. Next slide. It's really important for the young person to have a concrete, actionable plan for next steps, which, as I mentioned, can involve figuring out who to talk to in their life. And this is especially important for people who might be undecided or ambivalent. It's a good idea, if possible, to schedule a follow-up either with you or another trusted provider, like if they trust their primary care physician or a reproductive health provider, should they have one. Next slide. It's also important to provide referrals and review those referrals with the young person. If they know what they want to do and what type of practice they want to go to, you can help figure out what's closest to them or what's most accessible with transportation options they have. In some circumstances, you could even stay in the room with them and provide support while they call for an appointment. And if it's feasible to do a warm handoff, this can be very helpful. Next slide. A couple of our participants emphasized how important it is to provide appropriate referrals and resources and discuss them with the patient. As Raina said, I would want options to be spoken about, and then I would want to have something that I could reference later on and make a more educated opinion, be it a website or reading material, or maybe even a follow-up counseling visit. Whereas Destiny said, illustrating a negative example, they just gave me the pamphlets but didn't explain it to me. I think the only time they started explaining to me is when I told them, I can't keep her, I can't have a baby. Next slide. This is the compendium of resources we have in the Pittsburgh area. This isn't what we give to patients, it's our internal document. And then depending on what the patient needs, we might provide selected resources either in writing or help the patient put them in their phone or whatever format they prefer to receive information in. Next slide. There are some caveats that apply for Title X facilities. For example, there's some requirements and then things that are prohibited. In terms of requirements, if requested to provide such information and counseling, it's required to provide information and counseling regarding each of the following options: prenatal care and delivery, infant care, foster care or adoption, and pregnancy termination. And it's required to provide neutral, factual information and non-directive counseling on each of the options and referral upon request, except with respect to any options about which the pregnant client indicates they do not wish to receive such information and counseling. The things that cannot be done include scheduling or arranging for an abortion, i.e. a warm referral, providing transportation for an abortion, explaining or obtaining signed abortion consent forms from clients interested in abortions, negotiating a reduction in fees for an abortion, or promoting or advocating for abortion. Although these limitations do not apply in cases in which a referral for abortion is made for medical indications. Next slide. So I'm going to turn things over now to Robin Watkins from Power to Decide, who's going to talk about an excellent tool that her organization has developed.
Hi, everyone. I am having an issue trying to get my video to start. There we go. Hi, everyone. Nice to be with you this afternoon. Let's see if I can go. All right, so I am excited to be talking to you about an educational material that we collaboratively developed with the American Academy of Pediatrics, or AAP, to provide pregnancy options counseling specifically to adolescents and young adults. And this material can be generalized more and used with folks who are of all ages, but the intended audience for the material that we developed is specifically young people. For this material, we both The goal was to, meet lots of the things that Laura just talked about that they learned from talking to young people, but we also conducted semi-structured interviews with some youth leaders who were trained as peer educators and had provided lots of options counseling. Based on those conversations and literature review, sort of an understanding of best practices around options counseling, we drafted an educational material and then conducted semi-structured interviews with a group of pediatric providers. So these are folks who were identified by AAP, but who are providing options counseling in their own practice to learn from them. And so this practice of sort of centering the people who would be using an educational material, this user-centered design process or informed by principles of human-centered design, really allowed us to understand what it was that young people need when they're making decisions about pregnancy options, and understand what healthcare providers need when they're having those conversations with young people. So as a result of both of those interviews, we went back, reviewed the material, finalized the design, and then shared back with the young people and providers, as well as researchers and folks who are on this call to solicit feedback. So, what the young people had to say in the interviews that we conducted are similar to a lot of the things that you've already heard. They really wanted neutral information that did not prioritize or did not try to sway them towards a decision that was really open and really gave them an opportunity to share where they were. They also wanted to ensure that educational materials that were provided were credible, and that they were something that a young person could use to share with an adult, in particular around the acceptability of parenting, as well as the safety of abortion, and sort of really understanding and feeling confident that the resources were really credible. And they also, I think you heard this already, but that young people really wanted specific, practical, action-oriented steps. So if I choose this option, this is what will happen. So, or here are the things that I need to do next if this is the choice I make. And folks also, there's a typo there, but folks also discussed that they had a general understanding of what it meant to be a parent, and they didn't necessarily need information that told them specifically what it means to be a parent or what that looks like. Yes, they need resources, but defining parenting wasn't something that they needed, but that there were sort of knowledge gaps both around what it means to choose abortion and what it means to choose adoption, and sort of what that, or plan for an adoption, and what those processes really looked like. And so they really wanted specific information about those two, rather than specific information about what it meant to parent. And when we talked to the providers, they discussed some issues around the size of the document, sort of what is the form factor that would be most useful to them and to their patients. They felt like having something that was 8.5 by 11, so like a standard letter size page that could be put in a document stand like the one that's seen here, or pinned to a bulletin board, but that they generally were not able to put up any posters or have any documents on the walls in exam rooms, especially in places where providers were sharing exam rooms. And so they wanted to have something that they could take with them from room to room. They also wanted to and suggested QR codes. The young people were also in support of that, to link to credible resources for folks who, for all of the resources. They also really talked about acknowledging that young people, I think you heard it in one of the examples of the young people, like, I took a pregnancy test, it was positive, but I thought it might be a mistake, so I just waited. And so there's some magical thinking around pregnancy and what happens. And it sometimes is very much tied to ambivalence, that folks are really hoping, like, well, maybe this will just go away. And so some language around the timing, and both that if you don't make a decision to have an abortion, that you will continue being pregnant, and that until you deliver, and whatever, or the pregnancy ends. And so really understanding and acknowledging some of the magical thinking that some young people have. Same typo on this one. They really highlighted that there was more of a knowledge gap around adoption as well, and really just sort of trying to understand, in particular, young people. I think it was highlighted by Laura around understanding, like, what is an open adoption, like what are their options, as well. So based on that, okay, so let's see. So here's the, you can see the educational material that we developed. The version that we co-developed with AAP is still in their processes of being approved internally, but Power to Decide has developed a material that goes based on some additional feedback to really capture a few additional points. So this is an example of the material that Power to Decide is developing. It is almost final, so I'll give you a QR code in the next slide to sign up for bedside or provider, so you can stay aware of when this will be available from the Power to Decide, where we keep all and sell all of our educational materials. So in this material, really highlighting for folks what it means to choose each of these options, connecting them with legal resources if they decide that they, need them, depending upon where they live and how old they are, and really linking to credible resources for folks and thinking through these really actionable, concrete next steps, while also acknowledging that, some people may know what's right or what they want to do right now, and others may not, and that both of those things can be completely normal and supported by their provider. We also talk about the difference between having a medication abortion and an abortion procedure, so that folks could have a better understanding of that. Some of these also link to resources for getting support for the options that they choose. And an updated bedside or Power to Decide version is coming soon, as I mentioned. So to stay tuned for updates on that and how to get it to use with young people, or all people who are choosing, or deciding about pregnancy options. You can use the QR code that's right here to sign up for bedside or providers newsletter. I can also share with you a link to get signed up if you're not already signed up. I'll put that in the chat. And hopefully that should be available soon, before the end of the summer. So thank you so much, and apologies, I am not sure who I'm passing off to next. Melissa.
I think it might be us. Let's see, click to start. Let's see if it moves forward. Yes. So I'm delighted to be here with you all. And I know we did introductions at the beginning, but I just wanted a chance to hear. We will be chatting through some videos and just hearing from our young person expert, Hannah Hu, about some reflections from some folks who have tried on options counseling. And we will talk about both the good and the bad. Hannah, I just want to give you an opportunity to share with the audience a little bit about you. It doesn't have to be too much, but just why you as a young person were inspired to reach out and join us on today's webinar.
Yes, I'm a current adolescent myself, as I'm a rising junior in high school. And I've noticed that the topic of pregnancy within my community is very taboo. And this leads to a lack of discussion and education and awareness. And I wanted to be able to contribute my opinions and ideas to promote more discussion and compassion, especially since this is a very relevant topic.
Well, it's just remarkable, and we're absolutely delighted that you reached out, and thank you so much. Our Let's see if I can. Lauren, can you please advance the slide? Today, we're going to be showing two different videos of individuals practicing options counseling. I want to acknowledge that these videos were created through the Adolescent Reproductive and Sexual Health Education Project that was originally completed by the Physicians for Reproductive Health and now is housed on the Advocates for Youth website. Both of them have amazing resources, multiple different PowerPoint presentations. If you are interested or giving a talk about adolescent sexual health, I encourage you to go there for resources, including these videos that we're going to share. Next slide, please. And so we're going to watch this first video, and then Hannah and I will have a curated discussion about it.
16-year-old Kayla, an honor roll sophomore, has previously come in for annual checkups and a bad case of the flu. She made today's appointment because she's been feeling unwell for a couple of weeks. She thinks it might be the flu again, as she is tired and achy and sick to her stomach when she eats. Hey Kayla, what brings you here today?
I have been feeling good lately.
Okay, what's going on?
Like, I've been tired and achy for a couple of weeks now. Like when I had the flu.
Do you have any fever?
No, no fever, but I've been feeling sick to my stomach when I eat or when I smell food.
You know, if you don't have fever, chances are pretty good you don't have the flu, but actually a lot of those symptoms are symptoms that a lot of my patients get when they're pregnant. When was your last period?
6 weeks ago.
6 weeks ago. And are you sexually active?
Yeah, I still see Anthony.
You see Anthony. And what are you two doing so that you don't get pregnant?
Well, we use condoms most of the time.
Use condoms most of the time.
Well, sometimes when we go out, we may smoke a little, and we don't because it feels better and we love each other.
Yeah, but if you're high, it impairs your judgment, and, then something like this happens. So, you think you're pregnant?
Well, I took this test, but my cousin said that they're wrong a lot.
What kind of test? A pregnancy test?
Yeah.
From the pharmacy? They're usually pretty sensitive. So, you've thought about the idea that you might be pregnant?
Yeah, but I can't get pregnant now. I'm not ready for any children.
I think you've done the right thing by coming here. Have you talked to anybody about this? This is an extremely difficult time for anybody.
I told my mom and Anthony and my cousin.
And what'd your mom say?
Well, she cried and she said whatever I decide.
Okay. Hey, Kayla, I really know that this is a hard time, and I'm really glad you came today because it's early in your pregnancy and you have some options. We can get you into prenatal care if that's the way you choose to go. If you want to terminate your pregnancy, it's early. We can get you in, and the procedure is very safe. I have a staff here who can talk to you about your options. Let me introduce you to them, okay?
All right. So, Hannah, I have a couple questions for you. What comes up for you when you watch this? How do you feel that interaction between Kayla and her doctor went?
So I thought that the clinician overall felt very supportive for Kayla. She seemed to be very understanding and checked in with how the patient felt, including how her family and her partner felt, like asking Kayla these questions to understand, better understand the situation. She addressed concerns that Kayla had and answered the questions and listened to what the patient was saying and to properly assess the situation. I did like how the clinician reassured the patient by saying that she did the right decision by coming for a checkup. I personally, for me, this would help reassure me that I'm in good care and make me feel a lot more better, confident, and less worried. Yeah, and I also liked how the clinician explained that since it's early in her pregnancy, she does have a couple of options, and and also her Kayla's feelings and concerns were discussed. There were a couple of parts that I felt could be improved or changed on. I don't really like how the clinician said that this is like a very difficult time. And it's kind of, it would make me feel worse, especially if I was already pretty worried about being pregnant. And also it kind of like, depending on the situation, it could come off as like assuming things, like maybe the patient is actually very excited about being pregnant, and this kind of downplays their excitement and would definitely make the patient feel pretty sad. Also, there is this one part where the clinician was addressing the issue of smoking, and it seemed sort of like judgy. The patient most likely already knows the consequences of smoking and probably feels really terrible about it and how it did impair her judgment, possibly leading to this situation. And kind of like the tone the clinician used and the way she said it definitely felt like a stab and would make me feel very regretful and a lot worse about the situation I'm in. And also, there's this one part where the patient explained that she did take a pregnancy test, but she was kind of she wasn't sure if it was like accurate, especially since a family member who she trusts told her that these tests are wrong a lot of the times. So even though the clinician explained that these tests are usually like very accurate and sensitive, personally for me, I would definitely still feel not so sure, especially since I was told by someone I trust that these tests aren't very accurate. So maybe offering like a retest could make me more like, it would kind of make me realize like, oh wait, I am pregnant and I should decide like what I need to do next. But overall, I did think the clinician was pretty supportive, and I think it was nice how the clinician kind of initiated the conversation, like was the person to ask questions, because as like a young person who recently discovered that they are pregnant, they probably are very confused and don't even know what's information that they need. And at the end, when they were talking about counseling, she did mention that she would introduce a staff member to come talk to Kayla about her options. However, I felt like she could have first familiarized Kayla with the terms she was using and made sure that she understood these terms, as an adolescent may not be familiar with things such as like prenatal care and what that encompasses. So making sure that they understand exactly what information they are about to get.
That's amazing, amazing insights. Hannah, thank you so much. I really appreciate how detailed you were and having some nuanced reflection, thinking about things from Kayla's perspective. Let's try one more video. Lori, can we advance to the second video, please?
"16-year-old Kayla, an honor roll sophomore, has previously come in for annual checkups in a bad case of the flu.
There you go. Thank you.
Hi, Emily. Nice to see you. How are you? What brings you in today?
I missed my period this month. It's been irregular before. When I was on the shot, I stopped getting it completely.
Right, that can happen on depot. That's really common. So is that why you went off the depot? There's lots of other methods we could talk about.
No, it was fine. I went off it when I lost my health insurance for a while.
Okay. Well, if you're off the depot, are you trying to get pregnant now? Or are you not trying to get pregnant? Are you doing anything so you won't get pregnant?
No, we aren't trying, really. We use condoms sometimes, but my husband usually just pulls out.
Oh, okay. Given that you missed your period when you came in, you told us it was 6 weeks ago. The nurse who collected your urine did a pregnancy test, and it is positive. How are you feeling about that?
Well, I do want to have a child, another child, but I'm not sure this is a good time. my job's not secure, and I really want to be there for my son while he's getting used to school.
Of course. So let's talk about all your options, all the information you'll need to make a decision.
Okay.
So one thing you can do is you can continue the pregnancy. We can set you up for prenatal care here at the office and make sure you have a healthy pregnancy just like we did for your son. You could also think about staying pregnant and an adoption plan.
I don't think I could go through the pregnancy and then do an adoption. What about if I decide not to have the baby?
Well, we don't do that here in this practice. So if you wanted to end the pregnancy, we would refer you to Planned Parenthood.
Is that safe? Would I still be able to have another baby later?
I really think you should talk to Planned Parenthood about it. The nurse at the front desk has the phone number, so she can give that to you before you leave.
How long do I have to decide? I want to think about it and talk to my husband.
Well, you're really early in the pregnancy, so you do have some time. Whatever you decide, let's make sure that next time you're on some good birth control so this doesn't happen again.
All right, Hannah, we're up again. What did you think about that interaction compared to the last video? I think some things were better and some things maybe weren't. What were your thoughts?
Yeah, so similar to the other video, I did like how the clinician listened to the patient and answered all of their questions thoroughly. They asked the patient how they felt about the positive pregnancy test and listened to what the patient had to say. I liked how the clinician mentioned all three options for what to do next and listened to what the patient felt about them. And I liked how the clinician provided resources for Planned Parenthood so the patients could get more information regarding abortions, especially since the clinician doesn't perform them in their practice. But in this video, it's important to know that the person already went through a pregnancy, so the clinician is assuming that they know terms such as like prenatal care and what that sort of encompasses. However, if the adolescent is going through their first pregnancy, they may not know what these terms mean, like I kind of explained before. So it's important to explain what they mean, or maybe ask them do you know what prenatal care is, and expand on what they tell you. This would definitely help them make an informed decision of what they want to do. And I did like how the clinician had relatively neutral language. However, in the end, when she said, let's get you on better birth control so this doesn't happen again, I felt like that was kind of unnecessary, especially since the patient did explain before that she did like the birth control she was on, but she didn't have a choice and she had to get off it because she lost her health insurance. So this kind of language would make me feel worse about the situation I'm in, especially since if I am not planning on being pregnant, which the patient in the video wasn't. But I did like how, I explained before, how the clinician wasn't as informed on the topic of abortion. So they provided information to the patient of where to get more information. However, the way she did it kind of felt a little like if I were the patient, I would feel worried by the way she kind of gave me the information. The tone she explained that you should go to Planned Parenthood, I can't tell you anything, go to Planned Parenthood. That would definitely make me feel more worried about abortions and worried whether they're safe or not. So maybe reassuring to the patient that abortions are safe, and you have the option to go to Planned Parenthood if you are interested and would like more information. But overall, I felt what I liked about this video was how the clinician was very detailed with how she answered the questions and explained the different options that the patient had.
Thank you so much. I have a couple of non-video related questions for you. And I'm just, again, so grateful for you being here today. And I'm wondering, what do you hope that healthcare providers on this call remember when it comes to talking about pregnancy options with young people? What do you hope that they're going to take away from this call or from this whole webinar today?
Yeah, so I would like, the one thing I think is a good takeaway is that there isn't, sorry, I'm in like a really awkward position right now, so sorry. But so one thing I would like them to know is that there isn't one correct way to approach counseling. Like you should definitely adapt how you approach it based on the teen's needs and how they answered your questions, such as how are you feeling. Try to stay like neutral with your language to not assume things such as how the teen is doing and their background. And to be mindful of what you say, because a lot of the times we will have good intentions, but from the way we say it, our impact might be not what we want it to be. And the impact is what the teen hears on their end. So make sure that I definitely like how the clinicians in the first clinician in the video reassured the teen that they made a good decision coming to the hospital, getting a checkup based on the kind of this what they were feeling like their health, the issues with like their health. I think that would make me feel a lot more reassured that I'm in a good position and I'm with experts and they will help me along this process. I think that I definitely, like I said before, like it's important to make sure they the adolescent understands the terms you are using to prevent any confusion, and kind of telling them that, letting them choose and their decision, and letting them know that their decision is like a good decision, and no matter what happens, that they will be all right. Yeah, and also provide any additional resources to the adolescent based on what you think they need, or if you would ask them like, would you like me to provide these sort of resources for you?
Yes. And then one final question for you. Just thinking about being in a post-Dobbs landscape. Are there things that as a young person or people around you are worried about or thinking about that you would want people on this webinar to know about?
So now that Dobbs has happened and like the abortion decision, I'm worried that many young adolescents who are pregnant and are in a state where it is illegal, that they may feel hopeless and worried, and the emotions they feel are definitely very overwhelming, especially if they are in a state where it is illegal, and not everybody has the resources to travel to another state. And I think it's important to understand that not everybody will have the opportunity to be able to go to another state in order to get abortion, if that is one of the routes that they wanted to consider. So, and realize that they are facing a lot of like societal and possibly family pressure, depending on some people definitely don't care. They're the type of people who don't care about what society thinks, but a lot of others definitely would feel that sort of societal pressure, and to be it's important to be compassionate of the situation that they are in.
Absolutely. Wonderful. Wonderfully said. Thank you so much for your insights. We appreciate you being here, Hannah. And I think we're going to turn it over to If, When, How.
Hi, everyone. If I can click, there we go. Great. Hi, everyone. I'm Elizabeth Lang from If, When, How, Senior Helpline Counsel. So I'm just going to click through, or try to click through some of these slides, keep us going. So really quickly, I did want to just share who we are as an organization, in case folks are not familiar with us. If One How Lawyering for Reproductive Justice transforms law and policy landscape through advocacy, support, and organizing. So all people, including young people, have the power to determine if, when, and how to define, create, and sustain families with dignity and to actualize sexual and reproductive well-being on their own terms. Let me skip ahead. So I just want to make a quick note about reproductive justice. Reproductive justice is a human rights framework that says that everyone has the human right to have children, to not have children, and to raise children if they choose to have children in safe and healthy environments free from violence. Next slide, please. Okay. So abortion in the legal landscape post Dobbs. Next slide, and actually if you could just go 2 slides forward. Thank you. Okay. So this is a map of the United States with the current state of abortion bans in the country. There are states ranging in shades of green. So in the dark green, you have states that have a total abortion ban. And then in slightly lighter shades of green, you have states with a 6-week ban or a 12-week ban or a 15 or 18-week ban. And then states in the lightest green, you have abortion is available. I will also note that there is Indiana is in orange because I made this slide in advance. Unfortunately, their total abortion ban went into effect today. Now, I'm not going to go into each individual state's law because I think the main point of what this map is trying to illustrate is that the legal landscape throughout the country is extremely confusing and constantly changing. Even as a lawyer, it has been very difficult to keep up with all of the changes and the individual differences between each state. And on our Repro Legal Helpline, we do receive questions regularly from people in states with bans as well as states without bans, because they want to understand what the laws are in their state so that they can make the best decision for themselves. Next slide. Okay, so the previous slide was abortion bans that affect everyone in the United States, no matter their age. This slide has another map of the United States, and there are states in dark green where, again, there's a total abortion ban, slightly lighter green for Georgia, which has a 6-week ban. And then there are states in bright yellow where there are what are called forced parental involvement laws for abortion. I'll quickly note Oregon is in the mustard green because it has a slightly different law than other states, and I'll go over that in a moment. But again, the main point of this map is to really highlight the variety of laws throughout the country that can impact the options available to someone not only in their own state, but in other states near them, if, as Hannah mentioned, they can and they choose to travel to another state for an abortion. Next slide, please. Okay. So forced parental involvement laws are laws that require a young person, typically someone under the age of 18 years old, to involve at least one parent or a legal guardian in their decision to have an abortion. There are what are called parental consent laws, which require a young person to have written permission from, again, typically one parent, but some states require 2 parents, or a legal guardian. Other states have what are called parental notification laws, which require an abortion provider to tell a parent or legal guardian about a young person's decision to have an abortion, usually at least 24 to 48 hours before the abortion. And then there are some states that require both consent and notice. There are any number of reasons why a young person cannot or does not want to involve a parent. So on the helpline, we talk to young people every day. Some of them simply want to make a decision about their body without involving anyone else. And then there are other people who can't involve a parent, even if that parent would consent, either because they cannot access a parent for some reason, such as incarceration or work, or because they have made the decision that telling their parent would create some difficulty in their relationship that they do not want to have with a parent. So in those states with parental involvement laws, the alternative is a judicial bypass. Before I go over that legal process, I do want to make a quick note about Oregon and Maryland briefly. So Oregon, there, like I said earlier, it has a slightly different law. There is a general medical consent law for anyone who is under the age of 15 years old, and it applies to all medical care, not abortion specifically. So if that young person cannot or doesn't want to involve a parent, there's no judicial bypass option in Oregon. Only the abortion provider can decide not to involve a parent or guardian if they believe that involving a parent would put the young person at risk of physical or emotional abuse or neglect, or if the provider believes it would not be in the young person's best interest to involve a parent. Maryland does have a parental notice requirement for abortion specifically, but again, there is no judicial bypass process. The abortion provider is the only one who can decide not to notify a parent, but there are more grounds under which a provider can make that decision than I just shared in Oregon. For time reasons, I'm not going to go into all of those specifics. Next slide, please. Okay, so like I was saying earlier, if a young person chooses not to involve a parent, their option is to get a judicial bypass. This is a legal process where a young person has to go in front of a judge to ask for permission to make that decision to have an abortion without their parent. So I think when thinking about pregnancy options counseling, it is important to know that the question judges in almost every state are considering in a judicial bypass hearing is whether they believe a young person is mature and well informed enough to make the decision to have an abortion without a parent. Or they could also decide that it's in the young person's best interest not to involve a parent. In most states, young people have the right to a lawyer, a free lawyer, to represent them during the judicial bypass hearing. Many states do require that the hearing happens within a specific number of days after the young person asks for the judicial bypass, because it's supposed to be quick so that it doesn't interfere with their ability to get care. In practice, there may be many reasons why it can take longer than a week. And as you can imagine, in some states with gestational age limits, that can really present an issue for a young person. And as probably is not surprising to many of you, the court process is incredibly confusing and difficult to navigate. So again, while judicial bypass is an alternative to talking to a parent, it is really, really important to acknowledge that a judicial bypass is by no means private, and it is by no means empowering for that young person. The young person is still being denied bodily autonomy because they are being forced to tell a complete stranger about their pregnancy and about their reasons for needing or wanting an abortion. Next slide. Okay, so in addition to the parental involvement laws and judicial bypass process I was just talking about, there are other state-generated barriers that apply to everyone who needs an abortion in some states, but maybe especially difficult for a young person to overcome. And I want to be clear, these barriers often existed even before Dobbs and are really examples of how the legal right to an abortion does not mean access to an abortion for many people. So again, these can include gestational age limits, which are increasingly a challenge in states such as Georgia with the 6-week ban, mandatory waiting periods before getting an abortion that can range from 24 to 72 hours, biased counseling requirements, the cost of an abortion, especially later in pregnancy, ultrasound requirements, and then distance to clinic. For young people, there may also be clinic-imposed requirements that are not actually legally mandated. So for example, parental consent laws in many states only require that a young person has written permission from their parent to get an abortion. And the law will say specifically what that written permission needs to look like. But we know that some clinics actually require a parent to physically come into the clinic with the young person for an appointment and bring multiple forms of state-issued identification. So Again, it may not be legally required, but for some young people, right, their parent may be consenting, but their parent can't come with them to the clinic because of work, because of cost, because of a disability. And so that really creates yet another barrier. School and supervision, right, as you can all imagine, court hours often overlap with school hours. And as Hannah actually just mentioned earlier, young people are getting lots and lots of conflicting information from multiple sources, and they may be really overwhelmed by all of the information that they're getting. And finally, some young people have other systems involvement, such as the family regulation system, that can create additional barriers. Next slide. Okay, so resources, actually, next slide. I want to encourage everyone, if you encounter a young person who has questions about their legal rights or any legal risk, please, please, please share our helpline information. We talk to young people every day. We actually specifically, when it comes to judicial bypass, we can connect young people to lawyers in their state to help represent them in a judicial bypass hearing. And we will get back to everyone within 2 business days, unless it's an emergency. Next slide. And these are just other ways in which the, if one how works on youth access to abortion. I want to particularly draw attention to our technical assistance support. So again, if you are a provider who wants to learn more about youth access in your state, we can absolutely help with that. I will share a link to the organizers of the event for our technical assistance form that you all can use to get in touch with us. And I will turn it back over, I think, maybe to Lauren for questions.
Yes, thank you, Elizabeth. And thank you so much to all of our panelists today. This has been extremely informative. We're going to now move into our Q&A portion of the webinar. So thank you to all of you who've been putting your questions into the Q&A. If you haven't already, feel free to enter your questions now. I don't know if we'll get to all of them, but we have quite a few and we'll get to as many as we can. And then panelists, feel free to just chime in if you'd like to answer. So sorry we're running over a little bit late, but we do want to address everyone's questions and we'll stay on. So the first question is from Leisha. Why should we not say end the pregnancy if that's factual? I was always told to say that instead of abortion, since that's a loaded, politicized word.
So I can start by answering that question. I think, when communicating with anyone, but especially with adolescents, it's important to use clear language. As Hannah mentioned, several times, young people might not know the meaning of certain words. And, end the pregnancy can be quite confusing. I think it's important to be clear with people that the option is to have an abortion and what that means. So, to start just for clarity's sake, then from a political standpoint, I don't think it necessarily needs to be a politicized word. It's a medical word, even though, it is highly politicized in some ways, like refusing to say it out of fear of it seeming politically laden is ceding ground to people who stigmatize the concept of abortion. So I think it's important to be clear as well from that perspective. And end the pregnancy technically isn't accurate because there's multiple ways a pregnancy can end. A pregnancy can end in delivery, a pregnancy can end in a miscarriage, and a pregnancy can end in an abortion. So I don't think that's particularly clear language. But like I mentioned in my presentation, if the young person, understands that what's being discussed is abortion and starts using language like end the pregnancy, I think it's appropriate to reflect what they're saying for their comfort.
Thank you so much. Our next question is from Lottie Brewer. Alongside these pregnancy options, do you share information about safe haven or safe surrenders laws, or is that something you're more likely to present based on an individual circumstances later in pregnancy or soon after birth?
Again, I'm happy to answer this, but I don't know if one of the other panelists wants to chime in as well. From my standpoint, I don't routinely share that information. in an initial options counseling conversation unless asked about it. And that's just my practice. I don't know if one of the other panelists wants to weigh in on that too.
I agree.
Okay, thank you. This one is anonymous. For pregnant women electing to have an abortion, will the mother be at risk of seeing her aborted fetus? And how do you prepare young people for this experience? I'm thinking particularly about medication abortions.
That's a very interesting question. Unless somebody asked about that specifically, it's not something that I volunteer information about, again, in an initial options counseling conversation. Like I mentioned in my presentation, it's important not to provide too much information in an initial conversation to avoid overwhelming someone or, sharing too many facts. So I think unless the conversation kind of goes there or the young person seems to want information about it, I don't necessarily think that's part of like an initial encounter. That's just my practice.
I'll add something here. There's some interesting research about what folks are sort of expecting to see and what they actually see, and that many folks, when appropriately prepared, are really feel comfortable with what they see. So I'll see if I can find some of those resources and that research that was done. But there's a lot of support for like offering or just like having conversations with folks about what like providing some anticipatory guidance, like this is what you might see, and providing really matter of fact information for people, and that folks are really responsive to that.
Thank you. Okay, what are some options for young people when they are unable to care for their baby postpartum or change their mind? We see a lot of that. That Department of Child Safety tries to keep children in their home. Are there other options outside of this?
I feel like I'm answering a lot of questions. Would someone else like to answer, and then I can chime in and add something? If nobody is going to chime in, I'll answer. So I think one of the questions alluded to like safe haven laws. That's like one thing to think about. It's also not a terribly uncommon situation for someone to consider adoption after a trial of parenting. Like in our study that we did, a number of people in the adoption subgroup had tried parenting first, and for whatever reason, feeling overwhelmed, feeling like they didn't have resources, then subsequently placed their child for adoption. So if someone has tried parenting, it doesn't necessarily mean that adoption is off the table either.
Okay. This is a question for all speakers. A lot of the case scenarios or narratives focus on the next steps once pregnancy is confirmed, but wondering about offering some of this information content in advance. Would it be appropriate or impactful to share abortion info during other health interactions?
Again, if somebody else wants to answer first, I defer to others, but then I'll chime in too.
I think is a great question, a really great question. And I think it's something that it is a nice opportunity. We routinely ask people of all ages kind of what their goals are and kind of what they're thinking about their reproductive futures and kind of how important it is to them, and to try to gauge a sense of working with them in a very patient-centered and shared decision-making capacity to make sure that they get to achieve their goals. And so starting some of those conversations in advance, like how would that be for you right now, can be a valuable tool. But I think you're exactly right and wise in the question, is that that's probably something we could do more of.
Yeah, and I'll just say I completely agree with that. Anticipatory guidance around pregnancy options in an ideal world would be part of discussions about contraception, or even discussions in a subspecialist office about prescribing a medication with, for example, teratogenic effects. But it's not happening as much as it should.
Great. If a client states that they already know, oops, scrolled up, we got more questions. If a client states that they already know what they want to do with pregnancy, should you offer to discuss the other options?
My practice is to at least touch upon everything in a brief way, but not belabor options that someone has stated they are not specifically interested in pursuing. Like, you can at least say, like, you know, are you aware of your other options? This might include, you know, X and Y. If you want to talk about those, I'm happy to discuss further. But I think if somebody is very clear in their decision, I don't think it's necessary to go into a lot of detail and overwhelm them with information.
Okay, we have a couple more. Hi, Elizabeth. Can you talk again about how Elizabeth left? Well, I'll ask it anyway, and if anyone else can answer, we'll go for it. Can you talk again about how youth in foster care access abortion in states with parental consent? Does the parent need to give consent, or the state is the parent in that scenario? And if there's no thoughts, we can forward that on too.
I just think that that's probably going to be very state specific.
Mm-hmm. All right. And then our last question, any advice on how to mitigate feelings about perpetuating the harmful colonial adoption system?
That's an incredibly insightful question. There's a lot that's problematic in adoption in the United States. There are some adoption agencies that focus in particular in working in an empowering way with birth parents of color. One I'll throw out there is PACT. It's based in California, but they work with people on a national level. So I would just know, like, what agencies come from more supportive philosophies to be able to connect people to organizations that will be helpful for them.
Awesome. Well, that is all the time that we have. We want to thank you all for your thoughtful questions, and a huge thank you to our panelists for their time and effort in keeping us informed. As a reminder, this webinar will be made available on the AHI website. So before we wrap up, we'd like to encourage you to visit AHI's sexual health website for access to informative resources such as our power meetings, timely topic trainings, and Spark trainings. And we also hope that you'll join us for our upcoming connection session on Wednesday, September 20th from 11 to 5 p.m. This is a hybrid event with the in-person portion being held at Eastern Michigan University. Registration is open and closes on September 8th. Please note that you'll receive a follow-up email with a short survey, but we're showing you the QR code for you to take it now. Your feedback is extremely valuable to us, and we appreciate your time taking it. So thank you, everyone, and have a great day.